So I just we've got 5 minutes left. Okay, so this is going to be a fairly quick jaunt through this. I am available afterwards if you want to discuss anything. Alison asked me to talk a little bit about nucleoside treatments because they're topical. I put this slide up before to illustrate some of the ways that we might target treatment of mitochondrial disease. And there are various things that we can do, one of which is to restore the amount of mitochondrial DNA present when it's depleted. We tend to think about mitochondrial DNA in terms of heteroplasmy. This is mainly an adult onset disorder, or most of the patients who have mitochondrial DNA disease, I should say, are adults. But in terms of the patients that come to see Victoria, Shamima and myself, about 75% of those patients actually have nuclear genetic disorders. But a proportion of those nuclear genetic disorders can affect the amount of mitochondrial DNA around. So when you've got a defect in one of these genes, it affects the replication of mitochondrial DNA, and in fact what happens is we get fewer molecules of mitochondrial DNA in these patients, a situation known as mitochondrial DNA depletion. And the classic nucleoside therapy around this disorder is looking at replacing some of the building blocks for that depletion. So these building blocks are nucleosides. These are nucleosides here: adenine, thymine, guanine, and cytosine, and they're the building blocks of DNA, in this case mitochondrial DNA, and there are metabolic pathways within the mitochondria that lead to the very basic building blocks for that DNA, the adenine, ATP, GTP, CTP, and TTP. And those 4 nucleotides, those are used to synthesize mitochondrial DNA. Now, what happens when there's a problem in that? So one of those genes that can go wrong is TK2. And that TK2 enzyme is in here in the mitochondria. And my slide seems to have gone off the end again. What a pain. What a pain. So if that enzyme's not working, then that pathway from these nucleosides, which are in the cell, to make the nucleotides, which then make the mitochondrial DNA, is blocked. Now, fortunately, there is an alternative pathway, and we could give cytosine and thymidine into the body so that it gets into the cytoplasm, because there's this pathway. And so the idea is that if you give those, you can bypass this blockage, and that those dinucleotides, as they are here, get imported in. Trinucleotides here get imported in to the mitochondria at a later stage. 2 minutes. God. So there are some mouse models of this disease. The mouse has brain and muscle involvement, which is slightly different to humans, whereas just the muscle. Some natural history studies that have just recently been completed. This is the publication in relation to that, a study that was done by Michio Hirano. The headlines from that study are that 5 patients with early onset disease did much better. 3 of 8 non-ambulatory, so they weren't walking at the beginning, gained the ability to walk. And 1 of 9 patients who were on a ventilator at the beginning actually got to the point where they could breathe independently. That's the headline results. That came out in May of this year. Who was in that trial? There were 16 patients. And this just reflects a little bit what Rob was saying in terms of inclusion criteria for rare diseases. You couldn't use strict inclusion criteria for this kind of study. 3 years to 61 years. What affects a 3-year-old can't possibly affect a 61-year-old. This is a huge disease spectrum. 9 males, 7 females, so the balance of gender and sex was fine. There weren't any controls. This wasn't a controlled trial. It was based on the natural history data, and I mentioned that in a previous talk. Acquiring natural history data can be very, very helpful. So this was historical natural history data we had on TK2, which told us this, that if you're disease was onset early, it was a very poor prognosis. Slightly later onset, the childhood onset ones, did much better living into 30s, 40s and 50s, and indeed 60s in this case. They received 200 to 400 milligrams per kilogram of deoxythymidine and deoxycytidine. What outcomes did they measure? Well, they looked at survival, they looked at mobility, and they used this fairly crude test called the 6-minute walk test, but you can see basically from this that some people didn't seem to respond very much at all, so they're walking pretty well to begin with, and they were still walking pretty well at the end of treatment. Some people, however, were only walking just about 200 metres at the beginning and doubled that distance, and some people weren't walking at all, and then were walking up to about nearly 400 metres at the end of the trial. So that looks pretty successful. Ability to breathe. They looked at nutrition. They looked at side effects, and there were some side effects mainly related to diarrhea, and they noted liver damage in 2 other people who were taking this drug independently but not actually in the clinical trial. So what does this mean in terms of treatment? Well, effectively that it's safe, that it is effective, that early onset patients seem to benefit better, but benefits were seen in nearly all patients. Would anyone else benefit from nucleoside replacement therapy? Well, it's possible that patients with a deficiency of this enzyme, RRM2B, might benefit from that. We don't know which nucleotides to give, which combination, what the proportions are that we should give. But we are running a trial in Newcastle called the Prosper 2B, which is an observational study. There are 2 arms to this. One of it is doing a sort of deep phenotyping, in other words, looking at the clinical information available. We'll be looking at sit to stand, we'll be looking at respiratory lung function in these patients, walking ability, gait, ataxia, and where possible doing an MRI scan. There will be visits at baseline 4, 8 and then subsequently 12 months. The other arm of the study is looking at fibroblasts from these patients and designing molecules that might improve the efficacy of these nucleosides. So modifying the nucleosides so that they are better absorbed, so they are getting into the cells much better, and more importantly, getting into the mitochondria. And that's a collaborative study between Cardiff, Cambridge, and ourselves in Newcastle. Right. Whew. That was a bit whistle-stop, wasn't it? Any questions? Am I allowed any questions?
Can I ask a quick question?
What did you just say? Is the first question.
Can we have it in English now?
Okay, so
can you keep the microphone? Is that all right? Thank you.
of course. So the bottom line of that is that a trial has been done looking at some chemicals that can help synthesize mitochondrial DNA in a particular form of mitochondrial disease called TK2 deficiency, and that seems to work. The trial wasn't terribly specific by the fact that it's a rare disease, that they had to include everybody who had that disease to make meaningful numbers, but it does seem to work across the board, and early onset disease seems to be better. It might be that we can extend this kind of therapy, nucleoside replacement, to some other forms of mitochondrial disease, particularly RRM2B. People have talked about using nucleosides in POLG-related disorders. The logic for that is slightly different, in that there's no problem getting the nucleosides into the mitochondrion, and that's where POLG does its work in converting those nucleotides into DNA. If you're supplying sufficient nucleotides already, why would giving more nucleosides work? So that is it's an area for discussion at the moment, because sometimes things work and we don't understand why they work. And that's the limit of our knowledge.
Is this trial intending to produce a tablet or something like that that will help with their deterioration or to keep them on a steady?
So the RRM2B one is indeed trying to look at modifying these nucleosides. So one of the problems is they had to give quite big doses of nucleosides to get the effect. And it seems that those aren't working terribly efficiently. To get to where it needs to go, the drug has to go across the cell membrane. It then has to go across two membranes in the mitochondria. And we want to try and make that process much easier. And so there are ways that clever chemists can alter molecules to make them do exactly that more readily. And we've combined with a clever chemist in Cardiff.
Okay, thank you so much to our speakers today. I'm sorry I rushed you.